It's a fairly large topic, and I just cut down some of my slides because I had too many. So I'm going to be going a little bit fast. If you have extra questions, we'll have some time at the end so we can kind of delve into things. If I go over something a little bit too quickly, we'll have some extra time. So a few disclosures I have to show at the beginning of any talk I give. Here's what I'm hoping to do. So first question is, why do we even consider surgical therapy in Parkinson's disease? And then we'll talk a little bit what deep brain stimulation actually is. We'll talk about who's a good candidate, how is the surgery performed, what happens after surgery, what can go wrong, and then a little bit about the long-term efficacy, safety, and then a little bit about the provocative future of surgery in Parkinson's disease. All right, so why do we consider surgical therapy at all? We have all these medications we just heard about from Dr. Christine that work for Parkinson's disease. And there's more coming, right? So all these medications, but sometimes, and usually the way this works, patients with Parkinson's disease, as you all know, after a certain number of years, develop motor complications. So this works. And when the medications don't last as long as you'd like. You take the medication, it helps your symptoms, but eventually, within a few hours or so, you start having off symptoms. Or you get into a situation where you have dyskinesias that are occurring from the medications. And so despite having a great neurologist and working with them and trying to find the right combination of medications, taking the medications at just the right period of time, you still are in a situation where medications are either working and your symptoms are alleviated, or as the medications wear off, you have more of your Parkinsonian motor symptoms. And this is something that's just unfortunately kind of where the state of treating Parkinson's is with medications today. So that's when you start thinking about deep brain stimulation, when the medications are not able to control the motor symptoms enough throughout the day. Not when the medicines aren't really, quote, working, but that they're not working consistently throughout the day despite trying to make medication adjustments and trying different combinations of medications. So what is deep brain stimulation? Let's just show of hands. Does anyone here not know what deep brain stimulation is? Wow, look at that. So it's amazing. This has been a treatment now that's been around for 20 years, so it's wonderful that it's finally well known amongst this kind of community. But just to review then, for all of you, since you already know, it's an implantable device that helps modulate brain activity to improve the motor symptoms of Parkinson's disease. And this is a cartoon of someone who has a deep brain stimulator in place. There's an electrode that goes into the brain. It's also known as the brain lead. It's connected to an extension wire that goes under the skin and connects to a battery, also known as a neurostimulator or implantable pulse generator, or IPG. And this is all under the skin, totally contained. It also comes along with a physician programmer that can adjust the device and a patient programmer that can turn on and off the device and make adjustments to the stimulation itself. We have other types of neurosurgical procedures that we can also do for patients with Parkinson's disease. In the past, before deep brain stimulation was discovered or invented, we used to just make a hole in the brain, an ablative procedure, a thermal injury to the part of the brain in similar position to where we put the electrodes now. And for some reason, by just causing a lesion in the brain, you could improve motor symptoms of Parkinson's disease. Now with the advent of DBS, we don't have to destroy tissue in the brain to get improvement of symptoms. We can put an electrode into the brain, we can stimulate there, and we can get similar improvements. To just give you some basics about the DBS system, like I mentioned, there's a brain lead that goes into the brain, and on the end of the conventional type of DBS lead we're using today, there are 4 different contacts. They're labeled 0, 1, 2, 3, and the physician can decide which of these different contacts to use in the brain to try to deliver therapy. And then we can also make adjustments in the intensity of stimulation, or the amplitude, or the pulse width, or the duration of each stimulus, which helps the stimulation to, if it's a greater voltage, penetrate the tissue and have a wider effect. And also we can adjust the rate, or the number of pulses per second. So there's a lot of variables we can adjust to try to tailor the therapy for each individual patient and their symptoms. So how does DBS work? It's still a bit of a mystery, but think about it this way. We know in the brain that there are these interconnected motor circuits that occur. There are neurons that are starting up here in the cortex of the brain that help to control your motor function, and they project down into deeper structures of the brain that are part of the basal ganglia. And then these structures that are in the deeper part of the basal ganglia then project back to the thalamus and then back up to the cortex. And we know in Parkinson's disease, because of the loss of dopamine and other factors, this circuit kind of starts to become overactive and inflexible to information, and there's a lot of abnormal patterned activity. And somehow, by introducing an electrode into that circuit, we can disrupt that abnormal activity, that locked-in kind of state, and we can influence more normal activity for coming through, and people can have improvement in their motor symptoms. So who is a good candidate for deep brain stimulation? First of all, you have to have Parkinson's disease. That may seem obvious, but not all patients who have Parkinsonism have Parkinson's disease, and some of the atypical Parkinson's syndromes don't respond well to DBS. Also, in modern day, we really like to make sure people have tried reasonable medications before thinking about having an elective brain operation. So that means not just trying Sinemet 3 times a day and then going for surgery. It means trying, some of the other medications as well at appropriate doses, so that it really makes sense to kind of take the risk of surgery and put you through that. We also like to see patients have a continued response to levodopa. I'll talk more about that in a second. It's patients really should have some degree of disability before thinking about having surgery. We've seen a few patients come to the clinic and say, well, I just want DBS now because I'm young and I'll be able to handle it, and I'm going to get it anyway someday, so but you say, well, do you have a disability? No, I have no disability. Well, that's not really the time to think about DBS yet. Also, the absence of significant dementia or depression. We know that DBS can sometimes worsen people's memory and thinking if they have dementia already, and so we don't like to operate on patients who have significant dementia. Also, depression is common in Parkinson's disease, so this should be treated before thinking about having an elective brain operation. The absence of other surgical risk factors, we'll talk about those in a second. Having realistic expectations, we'll talk a little bit more about that as well. And there are some exceptions to this rule in terms of patients who have severe tremor. As you all may know, there are variants of Parkinson's disease called tremor-dominant Parkinson's disease. And despite giving them levodopa or other dopamine agonist medications, that tremor just does not really go away. And so in these kind of situations, DBS can be incredibly helpful, because DBS does help tremors very significantly. And then people who have severe dyskinesia, someone who takes a little bit of Sinemet and they just get wild dyskinesias, I think we would consider DBS earlier in those cases. So if you're thinking about DBS, what happens? At UCSF, this is what our typical workup looks like. First, we take a careful history, we go over what's happening, we try to optimize medications as much as possible. And then if we're really at the point where we really can't do much more with the medications, we would then have you come in and do more detailed motor testing, which is we call it on-off medication testing. Explain that more in just a second. We also have you see our neuropsychologist and have a complete neuropsychological workup so we can understand any deficits you're having in your cognition or memory or mood. And also, we'd like everyone to have a preoperative brain MRI. Sometimes this can be done within the last 5 years or so, but if you haven't had one, we'll reorder it. We want to look for any evidence of excessive brain atrophy, other severe vascular disease that may have occurred. If you have concomitant hypertension or depression, that may increase your risk of surgical problems. And then just looking for any other reason why you may have Parkinson's disease that we hadn't been aware of before. Here's a patient who's in our clinic, who has come to the clinic off medications to see if she's a candidate for DBS. So this means she holds her medications for 12 hours and then comes to the clinic usually around 8 o'clock in the morning. And we perform this detailed UPDRS testing, which we videotape to document the degree of motor burden she's experiencing. And then we have her take her medications, and we do the same thing. And as soon as she starts to feel the medication's working, we retest her. And what insurance companies, sadly, now have some say in this, like to see is about a 30% improvement in symptoms, and they like to see a motor score of at least 30 on the UPDRS. So it's also beneficial for justifying surgery to insurance carriers. But it helps us to really understand the patient's symptoms to a greater extent. One thing that we've known for a long time is that the degree of benefit people get from levodopa, even a single dose of levodopa, really correlates highly with the degree that they're going to benefit from DBS. So there's something about having that still intact, an intact biological system that's using levodopa that allows us to see that there's still an intact circuit that can be modulated with DBS. So this is highly predictive, and that's another reason we like to do this on-off testing, is to see what gets better. So what does get better with DBS? I've kind of alluded to this all along the way so far, but we know that it can reduce on-off motor fluctuations. You're going to have more on-time after DBS with less off-time. It will decrease dyskinesia most of the time, and it will help tremor. It will also help to improve stiffness or rigidity, slowness of movement, bradykinesia, sometimes freezing, and sometimes shuffling if those symptoms improve with Synomet. And sometimes they don't as the disease advances. People have more problems with freezing of gait and shuffling that don't respond to levodopa. And in that case, we don't really expect DBS to help either. DBS does not help some things. It doesn't help your speech. It isn't going to make your speech less hypophonic. It's not going to help your swallowing, probably. It doesn't really help balance very much. So if you have a primary postural instability issue, DBS is not going to help that. As I mentioned, it doesn't help on medication freezing very much. And it doesn't help to control non-motor symptoms, as far as we know. The people have tried to study this. So your constipation doesn't get better. Your urinary symptoms probably won't get much better. Your drooling, fatigue, memory problems don't get better. So a little bit about the cognition. We know that memory and cognition are often impaired in Parkinson's disease. And so we really screen for this carefully, as I said. The way the surgery is generally performed is when patients are awake for part of the surgery, which I'll talk about in a minute. So if you have a lot of cognitive problems and you're not able to really participate with the surgical team, that poses a problem. And it's also relatively complex, long-term therapy that requires being able to communicate with your provider and give them feedback so it can be customized. So for those reasons, someone who has a lot of dementia, really DBS is a difficult therapy for them to get through and to get the most out of. And then sometimes we see worsening in cognition after DBS, penetrating the frontal lobe with an electrode. If someone already has major dementia, can make that a little bit worse, so we want to be careful. Also looking for other reasons not to consider DBS. If you have out-of-control hypertension, we'd rather not put a lead into your brain, which may result in more risk of having a stroke. If you have cardiac disease and you're on a blood thinner, we would want to understand if that could be temporarily stopped and if it was safe to do so, because you can't be on a blood thinner and have this type of brain operation. Other things like diabetes or being on steroids can increase your infection risk, which usually can be worked with, but it can increase your risk of having an infection. DBS is a pretty complicated therapy. I'm trying to tell you everything I can about it real quickly here, but it's important when people are thinking about having surgery that they really get fully educated about what this is about. It's not a cure for Parkinson's disease. It's just a treatment that we have, and it can be very powerful in some patients, but it can require multiple programming sessions to come back and work with with the programmer to find the most beneficial setting. So it's a long-term relationship. The battery doesn't last forever, and so it's just something that you have to buy into and be ready for. All right, so how is the surgery performed? Traditionally, the surgery has been performed in an awake way, so awake DBS, using this head frame here that you can see this patient is already wearing. This is a Lexel head frame that is placed on all patients. They then have a CT scan the day of the surgery. And then the CT scan is fused with the patient's preoperative MRI. And then we use stereotactic neurosurgical techniques to find the perfect trajectory to place the brain electrode, trying to avoid any type of vessel along the way, trying to avoid the ventricles if we can so that the trajectory is straight. And then we introduce a small, tiny microelectrode first, and we can listen to the neurons in the brain. And different structures of the brain have a different neuronal pattern. And so that helps us to isolate where we are in the brain. During that time, when we're listening to the neurons in the brain, we have the patient wake up. So they're lightened from their anesthesia. And we say, okay, we're going to now be placing the microelectrode, and we're going to have you talk a little bit, make sure your speech is okay. Let's see if your tremor is still there. And we're moving the arm to see if we can hear motor units that can respond to that individual neuron, which tells us we're in that motor circuit that we're looking to influence. And then once we think we found the exact place, we'll put the permanent brain electrode in. We'll turn it on while the patient is awake in the operating room, and we'll see if it helps their symptoms. And sometimes it really can, especially in patients with tremor. It often is better right away. Just some more pictures of kind of the planning software we use. Here's Dr. Larson, one of our neurosurgeons, getting ready to do the test stimulation. There's a new way that's also available now at UCSF that was actually developed by my colleagues Dr. Larson, Dr. Starr, and Dr. Martin in neurosurgery and neuroradiology, where patients actually now can have the leads placed in an interventional MRI suite. So instead of being awake in the operating room, patients are under anesthesia, general anesthesia for the entire operation, and we are able to place the brain electrode in real time using MRI scanning. So the patient, in this case, has a small skull-mounted aiming device placed on their skull, and then we can just find the perfect trajectory to place the electrode. So there's no recording of brain activity in this type of procedure, but we've now found a way to visualize anatomically exactly where we think the brain lead should go, and we can often do this in one pass. So it decreases the number of brain penetrations that patients have to have for the surgery, and it's just, in my impression, working with patients now that have been doing this for a while, it's nice to not have to be awake for the procedure. We've been looking to see if patients do just as well, because this is a new way of doing surgery. And we've done a small outcome study looking at patients 12 months after surgery of having surgery using this ClearPoint aiming device with the interventional MRI technique. And our results show that patients do just as well as patients who have the awake surgery in terms of their improvement in motor function. So that was nice to see. So we don't think it's better than standard awake DBS, but we think it's just as good. And so now we're kind of looking to see if patients have a preference when we're doing surveys and things. So if any of you are getting information in the mail about that or call someone, thank you for answering the questions. So what happens after surgery? So, sorry, a couple kind of gruesome pictures here, but sometimes people ask me what happens after surgery. So about a week after surgery, you'll come into the clinic and you'll have some staples in your skull, here and here, as well as some sutures in your chest wall here. And the nurse practitioner Monica, some of you probably know her, will take those out and look at the wounds and make sure everything's looking good. And then she'll start activating the DBS system. And so she'll go through each individual contact and she'll turn on each contact and just see how you're doing and try to find out some information, at least initially, as to what might be the best setting for you to start with. And then we'll set the settings very low and see how you do. As I showed you this slide before, but this is what we're doing. We're going to be testing each one of these little individual contacts and seeing what helps and what causes problems, and writing that down and coming up with the final settings that we think will be right for you. This is the end of the brain lead. This is kind of like a close-up picture of it. And what we can do is we can try to turn on and off these individual electrodes. Let's see if it's going to work. So this is the target nucleus here, this orange blob, and we can create a stimulation field that looks like that, or we can create a stimulation field that looks like this, or we can add them together, and we can really go for it and give a lot. So it really depends on what the patient needs. We can tailor the therapy. All right, what about medications after DBS? DBS is not a substitute for medication. It's complementary to medication. But usually after DBS, people can reduce their medications, especially if their electrode is placed into the nucleus called the subthalamic nucleus, which I'll talk about in a second. So it's not like you're not going to have to take medication, but you'll have less of a reliance on medication. And so for people who are having side effects of medication, it's also helpful to realize that you'll probably be able to lower that and not be relying on that as much because you'll have the DBS working for you. All right, so what can go wrong? Well, as I said earlier, stroke is something we always think about. And this is the main reason I think people don't think about having DBS, is they're afraid that they may have a stroke. The risk of having a stroke is still pretty low, but if it happens to you, it's very significant often. So you can have an intracranial hemorrhage, which is bleeding in the brain. These are CT scans here. And sometimes you only see that on a CT scan or an MRI after the surgery, so we call it asymptomatic. So even though you had a little bit of bleeding in the brain, there was no consequence to you, it was just a little bit. Sometimes though, it can be more significant, we call it symptomatic. So if you look at the literature, there's about a 1 to 2% risk of having a hemorrhage after DBS. And we have about the same type of stroke risk as well. It's what we quote patients in our clinic. It varies a little bit if you have more hypertension or more brain atrophy, etc. But that's the risk you're taking. Per brain lead, about a 1% risk. You can also have ischemic infarctions where there's no bleeding, but there's lack of oxygen flowing through a blood vessel causing a different type of stroke. So we're always interested in trying to reduce the risk, and there's lots of studies going on about this. We think that age, the older you are, slightly higher risk, more brain atrophy, we think might be slightly increasing your risk. There might be a slight increased risk for the GPI. This is the other brain target we use in Parkinson's disease, but that's really poorly studied. We think that in Parkinson's disease, rather than dystonia, there might be a little bit higher risk. And we're interested more and more in thinking about the number of microelectrode passes. So as I was explaining to you, the interventional MRI procedure really requires just one pass. And we think that probably makes sense, would have a decreased risk of causing a stroke. But there's not a lot published on this, so we need better studies. What about infection? So this is the other thing we think about. So these are some examples of infections over the wound that we've seen in our clinic. And here we usually quote about a 5% risk of infection. It kind of depends on how you define infection. Sometimes you put in a new system and you have an infection that's called a perioperative infection. That's happening right around the time of surgery of the original implant. Sometimes it's not so bad. It's just a superficial wound infection that can be cleared up with a little bit of antibiotics and everything's fine. So self-limiting, not that big of a deal. But other times there can be device involvement. So if the infection is going down into the device itself, then unfortunately the entire system has to be removed. And antibiotics have to be given for quite a while to just clear out the infection before the system can be re-implanted. So quite a hassle. And so that's the thing we really try not to have happen, because it really gives us, it's a lot for a patient to go through, and it really sets us back. But this is a reality, this can happen. And then sometimes after the batteries are replaced, you can get an infection in the battery pocket. And then rarely you see these delayed infections. Now the patients have had these systems in their bodies for 10, 12 years. There could be some wear and tear of just having this device in your body. And so we're starting to see some wound dehiscence or erosion of the device sometimes. So just trying to give you all the bad news after I tell you all the good news. These are things that are still something you should be understanding if you're thinking about this. A couple other things. What if your symptoms just are not getting better? What's going on? So first of all, maybe we had the wrong diagnosis. Maybe you didn't have Parkinson's disease. Maybe you had MSA or something. So making sure you really had the right diagnosis is one thing to think about. What if the device is not programmed correctly? So you got everything's in, everything's working, but your settings are not perfect. That can be an explanation. The lead might not be in the right place. So sometimes patients come to our clinic and they've been implanted somewhere else and we're evaluating them, it's not doing well, and sure enough, their brain lead is not in the right place. So no matter how much you program it, it isn't going to help. And then sometimes you have device failure. You have a dead battery, or you have a lead fracture. Here's an example of some fractures of leads. So these systems aren't perfect, and they can break. So these are things we troubleshoot in the clinic. I threw this in because this is kind of, just to keep you awake if you're not already awake from the gory pictures. So there's something called Twiddler syndrome, and sometimes patients have been reported to flip these batteries in their chest wall pocket, kind of like as a nervous habit or something. And it ends up coiling up the cable, and then that causes a fracture. So, I mean, you see it all, nowadays, but don't do that if you get DBS. Okay. What are the long-term effects and safety of DBS? So now we have pretty good data to suggest that it really, continues to help the motor symptoms of Parkinson's disease. There's several good studies now, up to 5 to 6 years after DBS, showing that we still have excellent follow-up. There's a recent study now looking at patients 9 years out from DBS, and patients really still showing overall improvement of 44% at 9 years, so that's pretty good. And it's still helping things like tremor. It's not helping gait quite as much at 9 years, but look what happens with posture and getting out of a chair. So at 9 years, like I was saying to you, DBS doesn't always help these axial, these symptoms that are kind of in the middle of your body as much as the symptoms that are happening more in the extremities. So the balance and the postural issues are still there. And that's something you often see as Parkinson's advances, that we're not treating well with DBS. So the bottom line is that DBS really seems to have a persistent effect on these motor symptoms, including tremor, bradykinesia, and rigidity. I would say tremor, rigidity first, and then I'd say bradykinesia. I see that creeping a little bit more in our practice over 10 years out. But the disease is still progressing under this, so keep that in mind. So a few other DBS considerations. So there are different types of batteries. There are single channel devices that just connect up to one brain lead. There are dual channel devices that this is actually backwards, that can go to both brain leads. They're a little bit bigger. There's a new rechargeable DBS system now made by Medtronic that is supposed to last up to 9 years, but you need to recharge it every other day for about 20 minutes. We also think about where we want to put the electrode. So this is an example of it being in the subthalamic nucleus, kind of the most classically implanted target for Parkinson's disease. But the globus pallidus interna is also an excellent target for Parkinson's disease patients. And then the thalamus is sometimes used for patients who have only tremor that we don't think will tolerate these other targets as well. There's been lots and lots of interest in trying to understand, should we put the electrode in the STN or should we put the electrode in the GPI in Parkinson's disease? And we've been involved in a clinical trial now for 12 years at UCSF. I can't believe it's been that long. It's going to finally finish in March this year. And we've been wanting to know this question. And there's been some preliminary results coming out along the way. But basically, both targets seem to improve motor symptoms about the same. And so that's great. We have two targets that can help. There are some subtle differences. A lot of neurosurgeons are trained in how to place the electrode in the subthalamic nucleus, so they're a little technically more experienced doing it that way. So if that was your surgeon, you'd want him to do that, right? And then with the STN, you can often have a little more medication reduction. So for some people, that's really important. Then the GPI, it allows for a little bit easier programming. The subthalamic nucleus can cause more dyskinesia-like movements, whereas the GPI doesn't really do that. So it's easier to program in the sense that you just kind of turn it on and you have to fiddle with it a little bit less. And then there might be a little bit less cognitive impact long-term in patients with the GPI. But the story is still evolving, and I think both are very good. All right, so a little bit about the future of DBS. I have 5 minutes left here. There's some new medical device companies coming into the market. St. Jude Medical is coming out with a DBS system. So it's always been Medtronic systems up until now. They're already approved in Australia and Europe. Boston Scientific is also coming out with a DBS system. They're in clinical trials right now. We're doing a clinical trial at UCSF. So if you're interested, let us know. And this system is different in that it applies constant current, and it has an 8-lead electrode instead of a 4-lead electrode. It also allows for a little bit more fancier programming and is only a rechargeable battery, which may last up to 25 years. There is a movement to think about using DBS a little bit earlier in the course of Parkinson's disease. There's a great trial from the German group that came out earlier, a little bit more than a year and a half ago now, studying patients with earlier Parkinson's disease who've only had Parkinson's about 7 years, and looked at patients who got either DBS or medication management alone. And the patients that went for DBS had a better quality of life. So there's some more slides on this. So there's this idea that maybe we should be thinking about using DBS a little bit earlier in patients. This study showed pretty good evidence that it improves quality of life, more than medication therapy. And then there are others, including David Charles at Vanderbilt, that are thinking about DBS even earlier. So what about the provocative idea of not having patients take all these medications for all these years? Why not do DBS a little bit earlier if it helps? Yes, there's the risks, but we're getting pretty good at managing these risks. So what about using DBS therapy now before motor fluctuations? And there may be a trial looking at this at UCSF that will be a site for in the coming years. All right, and then one last thing to just tell you about we're trying to do here at UCSF. We are trying to make DBS better. So there are limitations to DBS now. First of all, it's an open loop stimulation kind of plan, right? You have to make adjustments in your settings based on what you tell your programmer. Your programmer has to make an adjustment to wait and see if it works. And this is a time-consuming situation, and you may not always achieve full benefit. So we're trying to find a way to make a smart DBS system. We're looking for a pathological signature within the brain, some signal that we can measure, that we could then use as an input signal to the system, and then it could be more automated. That would allow for just that the system could adjust, much like a cardiac pacemaker only goes off when you're having arrhythmia. So in a DBS, we'd like that to be more of an interactive type of system. So Dr. Starr and his lab are working on this, and they have started to find some very interesting brain signals that we might be able to use as an input. So I was going to show one more video. Dr. Amanoff's climbing up the steps looking at me like, hurry up. All right, so this is just a patient who was off medications before DBS, and then here he is off medications with the DBS on. So for some people that are good candidates for DBS, you know, it can be life-changing. It really helps their motor symptoms, and this was somebody who had an excellent response to levodopa, but just had severe dystonia and dyskinesia in the on state. So I have a summary slide just to kind of go over what I was saying. Sorry, all right. So just to remind you, DBS is an established therapy for treatment of motor symptoms. It does require this implanted system that requires a brain operation that has potential complications. You can have DBS now in awake or in a sleep method. You need to work with somebody to tailor your systems, tailor the programming to your individual symptoms, and we're hoping that that will be less of a burden in the future with the new research we're doing. It's not a cure, it doesn't slow progression as far as we know, but it can markedly improve quality of life. So it's a picture of our great team, and just want to thank you guys again for all coming today and being a part of this.